I'd now like to introduce our next speaker. We will now be meeting with Dr. Hannah Lippman. She's the Vice President of Bioethics at Hackensack Meridian Health and the founding director of the HMH Bioethics Institute. She holds the Linda Farber Post Chair in Bioethics and is a professor of internal medicine at Hackensack Meridian School of Medicine. She's a graduate of Northwestern University with a BA in Econ, and she graduated Phi Beta Kappa. She earned her MD from Columbia University and then completed training in internal medicine at the University of Michigan, cardiology at Tufts, geriatrics palliative care, and clinical research at Sinai, as well as a bioethics certificate at Montefiore Einstein. She previously was the associate director for the Center of Bioethics at Montefiore, and she joined HMH in 2018, where she built a network-wide bioethics program offering clinical, organizational, and research ethics support, as well as education and mentorship. Dr. Lippman chairs the Bioethics Committee of the Medical Society of New Jersey, and she serves on NHLBI data and safety monitoring boards and participates in the IHI End-of-Life Care Accelerator. Her expertise includes bioethics education, shared decision-making, and resource allocation. Join me in welcoming Dr. Lippman.
Thank you so much for that introduction. The part that was most important here is that did geriatrics palliative medicine fellowship at Mount Sinai, and I'm very happy to be back with my Mount Sinai colleagues. So I'm going to share with you today my take on medical decision-making from an ethics perspective. My objectives are to describe models of shared decision-making, discuss the assets and liabilities, a little bit of advanced directives, consider how to contextualize existing advanced directives, and try and think about how we might shift our emphasis from a narrow view of how to apply patients' previously documented preferences to a more holistic approach to decision-making in real time from an ethics perspective. I have nothing to disclose, no financial or other conflicts. So I always start with a case, and I'm going to tell you about Mr. John Lee, who is a composite case of many of the cases I've seen both in my clinical practice and my ethics practice over the years. Mr. Lee is 68 years old. He has hypertension, hyperlipidemia, arthritis, chronic kidney disease, vascular dementia, and obesity. And he lives independently despite some functional limitations due to arthritis and obesity. He's a retired store owner, and he comes now to us, to the emergency department with delirium. The evaluation reveals a considerable uremia and a bit of hyperkalemia. Medical treatment for hyperkalemia and uremia is initiated, and nephrology is consulted. When the nephrologist who's covering her practice reviews outpatient nephrology notes that reveal that Mr. Lee previously, quote, refused discussion of dialysis and was encouraged to bring his family in to visit. So now we have a guy who has been very, very independent, who now comes to us. He's had outpatient care. He has uremia and hyperkalemia, and he has indications for urgent dialysis. And the decision at hand is whether to initiate hemodialysis. And I want to take a step back first and say, why is this a question? If I, a fairly healthy, almost 54-year-old woman, came to the ED without kind of being in that hospital system before with uremia and hyperkalemia, they would initiate dialysis even if I couldn't consent. They look for a surrogate decision maker, or they'd look, but if there was nobody available and it was reasonably urgent to emergent, they would initiate it. It wouldn't be a question. So why is this a question for Mr. Lee? And I want to frame this as a preference-sensitive decision. As a clinical ethicist and physician, I'm always looking at, when I'm thinking about medical decision-making, what's the clinical side of the decision and what is the value side of the decision? And how do we marry those to make the best plan of care for this person, this individual in front of us? So preference-sensitive decisions often have a balance of benefits and burdens, or there's a considerable bit of uncertainty as to the outcome. There may be more than one reasonable choice, and it's the patient's values that determine which choice is the best for them. There may be competing outcomes that have to be prioritized, classically extension of life versus perhaps being at home at the end of life. Or there may be some indication of previously articulated preferences that are relevant to the decision at hand. I'm not sure this is an exhaustive list of what makes a decision preference sensitive, but it's the things that I've seen in practice. And Mr. Lee, we have some indication of previously articulated preferences. I'm not quite sure what to make of the fact that he didn't engage in a discussion about dialysis, but it makes me want to know more in determining the best plan of care for Mr. Lee right now, especially given his multimorbidity, especially given the impact on his life that initiating chronic dialysis may have. We don't know yet that he's going to need chronic dialysis, but I'm thinking ahead. And I think that all is important to unpack in that moment when the physician, the nephrologist taking care of Mr. Lee steps back and says, wait a second, what's right here? So this mantra or saying is how I think about medical decision making in the big picture. And I often use it actually as a differential diagnosis when my decision making is going awry, when there's conflict. So decisions should be individualized, made through a shared decision making process, analyzing the benefits and burdens of each care option in the context of the patient's prognosis and values and priorities. And all of that gives us the goals of care. Goals of care, the term is often used kind of as a shorthand for, oh my goodness, this patient cannot achieve, given what's happening to them clinically, the standard goals that people want. Cure, relief of suffering, life prolongation. This is what most people hope for when they come to medical care. And we often only talk about goals of care when those goals are not achievable and we have to start thinking about what other goals can be achieved. But unpacking that, what I mean by decision should be individualized is actually the clinical side of the decision. How do we take the evidence base and apply it to the patient in front of us? That's not so easy in the geriatric population. There are many studies that exclude still older adults, and we have to extrapolate what we know from the evidence base to the person in front of us who is older, multimorbidity, et cetera. So that's the clinical side. And then also on the clinical side is the benefits and burdens. What does the person have to go through? And what might they get out of it? What are the achievable benefits, and what do they have to go through to try and achieve them? And then the value side for me is how people weigh those benefits and burdens. What are they willing to go through to get what benefits? And if there are multiple paths in front of them that achieve different goals, how do they prioritize those goals? This is very, concrete and intellectual for a very complex thing, but I find it really helpful to unpack when we have, complex cases. So individualizing the evidence base, what does somebody have to go through, what will they get out of it on the clinical side. And then on the value side is the person's values, again, how they order competing priorities, how much burden they're willing to go through to get what benefits. And that process of bringing those together is the process of shared decision making. And there are different models that I'm going to share with you about how the clinical team and the patient or their surrogate decision maker, when patients lack capacity, come together in shared decision making. Now, the prognosis is really, really important also on the clinical side, a clinical judgment of prognosis, because it limits the potential benefit. Too often I see individual interventions evaluated as if in a vacuum. And that doesn't work for older adults with complex multimorbidity. We have to take a holistic view of their prognosis so that we know what the potential achievable goals, what the potential benefits are. So I come back to this over and over again. Am I not is there some option from the clinical evidence that is not being seen or that we could try? Is something going awry in shared decision making? Is the prognosis very uncertain? So I use it as a differential when things are going awry. So I come back to this over and over again, so I emphasize it. And so when we're thinking about the value side, how do we understand people's values, especially, with patients who may lack capacity to tell us their values in real time? If we can engage in shared decision making in real time, it's much easier to unpack somebody's values and give them different scenarios and figure out the best plan of care for them. I was really impacted by the article a couple of years ago by Sean Morrison, Diane Meyer, and Bob Arnold, really succinctly articulating the challenges in advanced care planning. And I found this really helpful because what I see in practice is when we have a patient and we have a preference-sensitive decision in front of us for that patient, trying to understand the patient's values, I hear a lot, oh, this should have been done as an outpatient. We should just stabilize the patient and make sure they get out of the hospital so that they can do the real value-laden shared decision-making work with their primary doctor. And there's kind of a cycle of when the patient is outpatient, they're doing well. It's hard for them to think abstractly about what might happen to them in the future. And then when they're here in the hospital, the team thinks, well, it should have been done as an outpatient, so I have to get them back to there. And I really want to shift our thinking from that to how do we optimize real-time decision-making, given all the complexity, given all the conversations that may or may not have happened in the past. So this group, Sean and his colleagues really unpacked 8 steps needed for advanced care planning that culminate in advanced directives to work, noting that the evidence has not shown that advanced directives have changed or resulted in goal concordant care or improved end-of-life care. Advanced directives have been shown to alleviate the burden on the surrogate. If a surrogate can say, I have this document to turn to and I know what my loved one would want, they do that. But they really unpack these 8 steps that patients can articulate their values and choose which treatments align with their values. That's a complex process. That clinicians can elicit patient preferences, that preferences are documented, that documentation, those advanced directives, or somebody who can report on the patient's values, a surrogate decision maker, are actually available when the patient has lost capacity, and also the knowledge that those directives contain or the surrogate decision makers report has not changed since the patient made their statements. That surrogates actually use substituted judgment, base their decisions on the patient's values to decide when deciding on behalf of a patient, that advanced directives not only are available, but that are read and integrated into real-time conversations, and that previously expressed preferences are honored, and that healthcare systems commit resources and care delivery models to support goal concordant care. So they break down these 8 steps, and we can already see with Mr. Lee where, his outpatient nephrologist's attempt at advanced care planning didn't result in a clear sense of the patient's values in real time when he has presented to us. So they argue that if we continue to misdirect resources at an intervention that is not achieving its stated goals to improve goal concordant care at the end of life, that we will misdirect resources from what is effective. And also, if we have imperfect tools of advanced care planning, that there may be misunderstanding of what the patient's values are in real time. And we have these very static documents that might not exactly, or actually almost never exactly apply to the decision at hand. So we have to think about all of this and say, how could we better ensure goal concordant care? Goal concordant care is an important goal. So we have to think about how to optimize real-time shared decision-making. Now, this is a really complex topic. It involves communication skills, care delivery models, conversation guides and tools. It involves documentation strategies, lots of different things to optimize. It involves having time to do this, rooms in a hospital where you can sit quietly with people. There's so much that goes into optimizing real-time decision making. I'm just taking on a small slice of it from an ethics perspective. So when a patient has capacity, they engage together with a clinician or a clinical team to do shared decision making. I find it very helpful to unpack the different models of shared decision making and go back to those originally articulated in the early 90s by Zeke and Linda Emanuel. They articulated the informative, interpretive, deliberative, and paternalistic models of shared decision making between physician and patient. The informative model is, here's all the information, you mix it up with your values, you tell me what is right for you. On the other end of the spectrum is the paternalistic model, which is, I don't really need to give you information because I either know your values and will decide for you, or the values are that the doctor decides. Cultural values may still strongly lean that way. So the model is the doctor decides what's the right thing, and it's the doctor's values about that matter. Or it's not, important for that value exchange, or the patient may defer and say, I want the paternalistic model. I want you to decide for me, not only clinically, but also from a values perspective. What burdens are worth it? What goals can I achieve? And what are the most important goals I should go for? In the middle of the informative and paternalistic ends of the spectrum are the interpretive and deliberative. Interpretive is, tell me what's important to you, and I'll help you interpret your values and apply them to clinical decision making. People may not have experience applying what's important to them to these very choices, like, should I have dialysis? And the deliberative model is also an interaction, but the clinician in the deliberative model takes more of a teacher role and helps the patient choose which are the best outcomes. You should really have a healthy lifestyle, or comfort is the best thing to go for as a goal of care at this moment. And I find this really careful unpacking important, especially when there's shared decision making gone awry. Maybe our model is mismatched to the decision at hand, right? So maybe there's, I love to use urinary tract infections as kind of a slam dunk thing, that benefit of treatment is very high and burden is very low. So, maybe we don't even discuss values. It's here's your antibiotic. Or maybe there's a couple of antibiotics. One is once a day and one is twice a day. Which does the person want? So you use an informative model. So no one model is perfect for all situations. We have to be flexible in applying them. So when things go awry, maybe we're not applying the right model. The paternalistic model is out of favor in our individualistic way of looking at medical decision making. But again, we have situations where patients want to defer even the value laden concerns, the preference sensitive concerns to the physician. Okay. So let's turn back to Mr. Lee. Unfortunately, he lacks capacity, so he can't engage in that kind of shared decision making. So we have two questions. Who is the appropriate surrogate decision maker? We might need to know whether he has a proxy directive, and if not, who our quote unquote default surrogate is. Default just means not appointed by the patient. But a second question is just as important if we're trying to optimize real-time decision making. How do we get to know who Mr. Lee is? If we're going to employ any other model besides informative, here's the information, you mix it up and with the value-laden concerns and tell me what you want, we need to kind of know who this guy is. And we need to kind of know who's on his team, who's Team Lee from a personal perspective. We need to know if he has any advance directives, particularly a proxy directive that assigns decision-making authority to a trusted person, also called the healthcare proxy or durable power of attorney for healthcare. Somebody assigned decision-making authority by the patient in an advance directive, in a proxy directive, has priority over other decision makers. So we definitely need to know that. We also need to get a sense of whether he has what's called a treatment directive or an instruction directive in some states, including mine, New Jersey, also called a living will. A treatment directive expresses preferences about the kind of care that is preferred in case the patient can't decide independently. Now, I showed you that slide about the 8 steps for advance directives to be effective in achieving goal concordant care, and how there's breakdown in that, and how they haven't been shown to result in goal concordant care, but we still need to know whether the patients have those advance directives. But I think we need to change. I might argue that we need to change how we incorporate them into the care. The proxy directive is clearly very important. And in my system, we're really encouraging people to do proxy directives, all adults, so that they can have their preferred decision maker. Now, advanced directives are about what happens. It's about offering people who have capacity the ability to articulate what should happen to them if they lose capacity. They are not expressions of the patient's autonomy. They're trying to extend the voice of the patient to the point in time where they may be unable to exercise their own autonomy for themselves. I think it's really important to make that distinction between the patient's voice in real time and the patient's voice from the past, from an ethics perspective, because when we're looking to the past, we have a sense that maybe things have changed. We're interpreting the statements from the past. We're learning about the context of those statements from the past from the people who can engage with us now, the surrogate decision makers. And that's a really important distinction. Now, Mr. Lee does not have advance directives, not uncommon, not surprised, given he was, we're sensing that maybe he was reluctant to engage in advanced care planning with his outpatient nephrologist. So he doesn't have a designated healthcare agent, and that's important to know. And he doesn't have a living will. Okay, so who's Team Lee? He's divorced, but he has a girlfriend, Barbara, who he's been with for quite some time. They don't live together, but they've been together for quite some time. He has 3 children, Susan, Joy, and Michael. And he also has siblings, 2 brothers and a sister, and grandchildren. So there's a large Team Lee. And when I see that, even if there's not necessarily agreement among the patient's team, I feel a sense of hopefulness that somebody here to speak on Mr. Lee's behalf, somebody we can pull into our care. Okay, so since he has no healthcare proxy and he has a number of people on the next of kin, how do we decide which of those people on Team Lee should be authorized to make his decisions? Now, state laws vary, so you have to know how what the law in your state is that says who to turn to when patients have not designated a surrogate decision maker. In my state of New Jersey, we don't have a state statute. We have a case law that allows family members and a close and caring friend to make decisions on behalf of the patient, but doesn't order them in a hierarchy. Other states have a clearly defined hierarchy and a clearly defined conflict resolution process among equal priority surrogates. So we've got a patient now with 3 children. What if they disagree? Some states require consensus, unanimity. Some states a majority. So you have to know the statute in your state. And I've included in my slides a link to an extremely useful document from the American Bar Association. I find it extremely useful, that has each state, and it lays out what the legal context is for knowing the authority of a surrogate decision maker. New York has the Family Healthcare Decisions Act, for example, in contrast to New Jersey that doesn't have a statute. That was in 2010 that lays it out very clearly and lays out the authority that surrogate decision makers have for different kinds of decisions, even limiting the authority for life-sustaining treatment decisions, which is important to know. They can only decide in New York in certain clinical contexts, not in every clinical context. So know your state law. And so what is the role of the surrogate decision maker? So now I'm unpacking the side of shared decision making that the surrogate is the role that they're taking in shared decision making. So what are surrogates supposed to do? Classically, we ask them, what were the patient statements? We give priority to patients' known preferences. Even trying to unpack and apply that can be challenging, but we need to know what the patient's oral or written statements are. And if the patient's preferences are unknown, surrogates are supposed to decide based on the patient's values to the best of their knowledge, which is called substituted judgment, which I mentioned earlier in the 8 steps that Sean and his colleagues laid out in the chain of things that have to go right for advance directives to help. So to do substituted judgment, the patient surrogate has to know the patient's values, have a sense of them, and also be able to apply them to the decision at hand. And taking a sense of what's important to the patient, say independence, spending time with grandchildren, staying out of a long-term care facility, things we commonly hear, and applying that even something as concrete as staying out of a long-term care facility is really sometimes very complicated to apply to the decision at hand. And if they don't have any sense of the patient's values, surrogates are charged with deciding what is in the best interests of the patient, balancing benefits and burdens as they deem best. Okay, so we turn back to advanced directives just to articulate what they are. A treatment directive is a living will. So if a surrogate is charged with basing their decisions on the known preferences of the patient, an advanced directive, like I said earlier, is important evidence of that, of those preferences. And advanced directives do relieve surrogate burden, but they're hard to apply. Living wills are if-then statements. If this happens to me, I lose capacity. They're only in effect when the patient loses capacity. So if I lose capacity, but often if I have a terminal illness or permanent unconsciousness, there's a lot of boilerplate language out there, then do this, forego life-sustaining treatment. That's the common living will. I love to cite a living will I saw once that I'm paraphrasing only lightly that said basically, if I'm unable to speak to myself or speak for myself, don't listen to my family. They don't know what I want. I want life-sustaining treatment no matter what. I want to give myself a chance to live no matter how I live. So that's a very important living will to read because it says the opposite of what we assume they do say. Living wills often leave out important preferences, so they're not sensitive. And the stated preferences, because of that boilerplate language, lack specificity. They may not be exactly what the patient meant to articulate or understood they were signing. They don't anticipate the current situation. Sometimes patients get a clear progressive illness and they can be very specific in a written advance directive, and that's helpful. But in general, they're often very boilerplate and hard to interpret. And so that interpretation that falls to the surrogate decision maker so that they can use that evidence of the patient's preferences to fulfill their role in speaking on behalf of the patient, working with the physician and clinical team in shared decision making. Note the difference between the surrogate decision maker's ability to go back and forth and have an ongoing dialogue with the clinical team and the living will's one-way communication. We can't query the living will about what the patient would want in real time. So we have to put it in context so we know what the patient, as much as possible, was trying to effectuate, what their goals were with completing the advance directive. And we have to account for the fact that preferences may change over time. It's also very, very hard, even when there is evidence of the patient's preferences, to fulfill this traditional surrogate role of patient's known preferences, applying patient's values, or deciding what's in the patient's best interest. Because patients have surrogates have their own preferences, their own way of living, their own sense of what's important to them. So there's a lot of challenges in being a surrogate decision maker that we need to account for and think about how we're going to adapt those models of shared decision making to the surrogate role to help them through the challenges of being a surrogate. We don't, I've already made the case that preferences are not accurately known. A surrogate may never have been involved in the patient's care. We don't know yet whether Mr. Lee ever had one of his team come with him, but he certainly didn't take up his nephrologist's offer to bring somebody to specifically discuss dialysis. The surrogate has to live by their own values. There may be their own commitments, and there is data to show that surrogates do base their decisions not only on the patient's preferences, but their own sense of their values about how the tools of medicine should be used. We don't know how much leeway often the patient wanted their surrogate to have. Should they be able to roll with the punches, or should they rigidly apply what the patient said they should do, et cetera? So there's a number of challenges. There's also enormous cultural variation in the role of families in taking care of sick loved ones, particularly their elders. And that presents challenges in effectuating, again, our very kind of Western individualistic autonomy focused model of decision making. So one of the criticisms of bioethics is that we always say it depends. And sometimes it does, a lot of times it does depend, but our job is to say, how does it depend? How do we take the specifics of a case and apply a rubric or framework for ethical decision making to understand the best way forward in a particular situation? Now, I appreciate this paper by my colleague Courtney Bruce and her colleagues looking at how to think about whether it's ethically supportable to override a patient's living will. So this is putting kind of meat on the bones of the sense that this interpretation has to happen in real time, and that interpretation is a shared decision-making dialogue between the surrogate and the physician and clinical team. So she offers two necessary conditions that have to be satisfied to make it ethically supportable to override what you think is articulated in a living will. I don't want a feeding tube. But now we're in a situation where maybe a feeding tube, a PEG tube is necessary. The surrogate wants it. Is it necessary? Is it ethically supportable to override that? So the two conditions that are necessary is that what the surrogate wants is actually medically appropriate. So that makes sense. You wouldn't want the surrogate to override somebody's preferences and choose something that was not appropriate. And then the second is corroboration, which means that the surrogate substituted judgment. I think this is actually what the patient would want, not what's written in that living will. I really think the patient would want a feeding tube in this case is actually a plausible interpretation of the patient's preferences. We don't have non-corroboration, I guess we'd call it, that says, multiple notes in the patient's chart that say, under no circumstances, I never want my body violated by having a tube through the abdominal wall, really things like that. So corroboration is that the surrogate's position as what the patient would want is plausible. And then either of these two, discretion, that's that leeway consideration. Would the patient have wanted the surrogate to say, I see what he wrote, but I think he would really want me to roll with it and make a different decision if it was warranted under the circumstances. That's discretion. And then purpose, maybe the living will is not actually a valid understanding of the patient's preferences because the patient may have misunderstood the nature of the living will. I have had one case like that in my ethics practice where the patient's daughter said that the patient thought she was just signing the designation of the surrogate decision maker, the proxy part, and didn't even read or see the part of this boilerplate document that said no ventilator support, no feeding tube, et cetera. So I offer this as a way forward, one way forward of thinking about this problem of advanced care planning, documents. How do we effectuate those in real time and really take ownership of real-time decision making? And this is a classic issue. The surrogate wants one thing, the advance directives seem to say another. How do we think about that? And this is what some ethicists have offered as an ethical framework for understanding that. I find this helpful. Okay. Mr. Lee, as I said before, does not have a living will. He's not particularly close with his children, but one of his children, his daughter Joy, and his girlfriend Barbara live nearby. So they're at the bedside and they are asked, should we offer dialysis? Okay. So now we have to think about our relationship with Barbara and Joy, and also the other two of his children who are not yet involved. And I just note that there are really significant differences in the clinician surrogate relationship, ethically important differences, than the clinician patient relationship. Not only what I said before about the patients with capacities, ability to exercise their own autonomy, and the surrogates not really exercising autonomy, they're having this different sort of ethical role in shared decision making, but some practical things. There's timing. Patients, especially in inpatient, they're there, and in outpatients, there's clear appointments, and surrogates come and go. So much time in ethics is spent tracking down surrogate decision makers and arranging meetings. There's also, I think, a different level of trust. I see so often where clinicians have kind of a baseline suspicion of the motives of surrogates. They're considering their own values often, and we've been taught that they're not supposed to do that. So there's this mistrust that happens that we need to unpack and rebuild trust. And surrogates and the clinician have completely different perspectives on the patient. They see a living loved one, and especially at end of life, clinicians often know the trajectory and see where this is going. And the surrogates see their loved one in real time. So Doug White, an intensivist and bioethicist, and his team, through empirical data, listening in on conversations between clinicians and surrogate decision makers in the ICU setting, offered an adaptation of the models of shared decision making that we learned from the Emmanuels between patient and clinician to the surrogate clinician relationship. And informative is the same. You give the information. What would your loved one want? Tell us what to do. And on the other side is directive. Here's what we're going to do. And in the middle, there are gradations analogous to the patient surrogate, the patient physician relationship. There are gradations of the increasing role that the clinician takes in the value side of the decision. Facilitative is tell me who your mom is, and let's work together to think about which options. You'll decide which option, but let's think together about which options really fulfill her values. And a collaborative is more the clinical team taking a role in deciding what the important values are, learning about the patient as a person, but saying, these are the values, this is the ethical goal that we should try and achieve. We should prioritize comfort over life prolongation or something like that. That's more collaborative. But the bottom line is that the clinician-surrogate relationship requires nurturing just as the clinician-patient relationship is. And you can see my palliative care background coming in. The family is the unit of care, part of the unit of care. From an ethics point of view, from a principlist point of view, we might say our beneficence obligations also extend to the family to help them and use our communication and our decision-making approach and everything to help benefit the family. So there's a lot written about how to approach your relationship with a surrogate decision maker, but just to put a point on it in this talk, from an ethics perspective, building relationships that help bring the patient into the room, learn about the surrogate. Who are they? What are they basing their decisions on? What other pressures do they have? How have they made decisions in the past? How do they like to work with a team if they have before? Things that the clinical team can do to promote a healthy surrogate clinician relationship. Designate a skilled communicator from among all of the multiple people taking care of a patient, etc. Especially, I'll emphasize the last point, focus on the big picture, not we could do this, we could do this, we could do this, we could do this, we could do this. Focus on the big picture about what goals can be achieved, and then choose the interventions that achieve those goals. Okay, back to Mr. Lee. Barbara, his girlfriend, Joy, his daughter, don't know anything about conversations with dialysis. They call. Barbara and Joy get Susan and Michael, the other children, on the phone. Michael recalls his father saying something like, I don't want to do that. This doctor's trying to push this on me, and I don't want to do that. Mr. Lee discussed other things with Barbara, but never discussed this discussion with dialysis. And the primary nephrologist, not the covering one in the hospital, but the primary nephrologist, reports asking open-ended questions and really trying to do her best advanced care planning, but that he was not into it. She did provide him with education materials about dialysis. Okay. So we've got to figure out now how we understand the patient, Mr. Lee's values, and what would he want in this moment. We have a little snippet of information to go on, but we're not quite sure yet how to apply it in real time. So we ask his family. Now, they don't agree. Michael said, I heard my father say he didn't want this, so why should we do it even now? We're just prolonging the inevitable. He didn't want it. He's never going to do it. His daughter Joy says, I really want my dad to decide for himself. So if you're telling me that a little bit of dialysis now will restore his capacity, go for it. And then ask him. I don't want to deal with it. Susan's like, I'm not close. I moved to California. I don't want to take sides. Barbara, his girlfriend, is like, I know what's best for him. I'll convince him to go. I'll drive him to dialysis, do it, and just get him there, and I'll take responsibility. I like to never as a decision aid with patients and families, but for us to unpack decision making, I like to visually represent patients' illness trajectories, borrowing from the classic illness trajectories developed by Joanne Lin. So on the y-axis is functional status, and on the x-axis is time. So Mr. Lee has been declining functionally, obesity, arthritis, et cetera. And now he's really declined. He lacks capacity. He's in kidney failure. What are the potential outcomes? And I find that visualizing it, we have an intervention. How do we know whether he's going to get right back to baseline like his daughter Joy hopes, and he can make his own decisions, or it might be a longer haul, but he might get there, or it's really not going to make a difference, and his illness trajectory will go towards declining function. I find that helpful to think through the clinical side of the equation so that I can better understand and help families to apply the patient's values to the decision at hand. So we have to decide who among these equal priority surrogates gets to decide. You have to turn to your state law, like I said before. And you also have to think about who Mr. Lee, who the patient at hand would want to decide. We may have evidence of those preferences. Okay. So now we have to decide, is the evidence for a refusal of dialysis strong enough to warrant foregoing it? Okay. Do we know enough to forego this intervention that might actually get him back to his baseline? I'm going to make a prognostic estimate. So we might consider a very useful tool, a time-limited trial. And we need to define that very clearly. What's the success? What's the goal of the time-limited trial? And articulate partnership with the patient and the people involved in his care to really check in to know whether our time-limited trial is succeeding or not. And that leads me to just note that in secular ethics, stopping something is morally considered ethically equivalent to not starting it. So if we do a time-limited trial, we have to have the ethical ability to withdraw that treatment when the trial hasn't achieved its goals. Withdrawing and withholding have very different emotional realities, and particularly in Jewish medical ethics, really are not considered ethically equivalent. So we really have to plan our time-limited trials well. And in the process of this, we've developed some goals of care from just this, array of potential goals. Right now, an achievable goal may be Joy's goal to see if Mr. Lee can decide for himself. One of the things that I have found most useful, and it was articulated in the Educating Practitioners in End of Life EPIC curriculum, it was also articulated very well by Doug White and his colleagues, that in order to resolve conflict, we need to understand not only the information, whether, what the clinical information is, but also the emotional context that people are making decisions in, and disagreements about fundamental differences in values about what the tools of medicine should be used for. And this story is articulating a really important maxim for me in medical decision making, that the process is the intervention. Yes, dialysis is the intervention. Getting to a decision is an intervention, but the process of building trust and working through how to apply the patient's values in real time is an intervention in and of itself that we need to attend to. Okay, so they all agree on a time-limited trial. I'm not going to analyze the conflict. That's beyond what I can do in this time. But we do all of our good surrogate relationship, and we listen to the emotional context, and we clarify clinical decisions, and they decide to do a time-limited trial of dialysis. And that illustrates a number of principles for medical decision making. I have some more in the slides, but I think I covered most of what I wanted to say, and I see the time's up.
Okay. Thank you so much, Dr. Lippman. I know it's a very complicated topic, and obviously these discussions can go on over days and even weeks and months. So thank you for doing what you could in the limited amount of time that we gave you. A couple of questions I have. Clinicians often struggle with trying to figure out what to do in terms of living wills. Do you find those to be helpful generally?
It really depends. One thing it tells me if a patient has a living will is that they took the time to do that, to execute that living will. I have seen a lot, and I think this really has a lot of regional variation. So I'm looking at my view from being in New York and now New Jersey. A lot of them are executed with attorneys. So, that was part of a larger estate planning thing. So I need to understand what the context of that was, whether it was ever discussed with a clinical person who could help contextualize it from a clinical point of view. If it was just a document that they said, sign this, this ensures that you're not going to get your life prolonged on machines or something like that, it's not as helpful. But if I can understand what the patient's goals in signing it were and what the context was, and whether it was ever discussed with the people who are now the surrogate decision maker, I mean, that's really great. Or if it was discussed with an outpatient, clinician. So I think they're a variable use. And that's why I offer that paper from Courtney Bruce, because one of the most common questions we get in ethics is, the surrogate, the daughter wants us to intubate the patient, but we have a living will. Well, first we have to understand whether the patient is in the situation that the living will covers, if they have a terminal illness, et cetera. If they may not. And then we need to understand the perspective of the daughter and the context of the living will. And I find that grid really helpful in thinking about when is it justified to go with the daughter. What we so often hear, I'm sure people have heard this, is, well, it's the daughter who can sue and not the living will. So there's a real strong medical legal fear, and then they go with the surrogate. It depends. Sometimes the surrogate's view is actually the right way forward. And sometimes that living will articulates something really fundamental and important that the surrogate really shouldn't override. And it does apply in real time, that living will. So I think we need to have a more nuanced understanding of how to contextualize and apply them to make them even more useful.
Thank you for that. With